Hi, my name is Abdul-Ahmed. I'm a PGY5 neurosurgery resident at the University of Maryland. It is an honor to present our recent clinical trial using bilateral focus ultrasound central lateral thalamotomy for refractory trigeminal neuralgia. Dr. Gandhi started this trial and has been an extremely gracious mentor. I have no disclosures. I want to talk about trigeminal neuralgia. How do we define it? What causes it? How have we treated it in the past, specifically medical and surgical management of trigeminal neuralgia? Then I want to talk about the central lateral nucleus, its anatomy, its history in treating pain, and why a thalamotomy or an ablation of that nucleus is valuable in some patients. I want to talk about our trial design and then our safety outcomes and our pain outcomes. Patients with trigeminal neuralgia experience recurrent unilateral brief electric shock-like pains that are abrupt. They're limited to the V1 to V3 distribution. If they have no immediate cause, it's considered classic. And if there's a secondary cause like multiple sclerosis, it's considered secondary. And the pain is triggered often by common activities like brushing the teeth or touching the face. And it is the most common cause of facial pain, about 10 to 15,000 new cases annually. 72% of patients have a neurovascular conflict, a vascular loop of one or more arteries and sometimes veins is causing compression of the trigeminal nerve root. There are several medications patients are often started on first, anti-epileptics like carbamazepine, oxcarbazepine, gabapentinoids, and baclofen. And then when those are not working, particularly if you have a neurovascular conflict, a microvascular decompression can be offered. A neurosurgical procedure, as you can see on the right, that was introduced by Walter Dandy and then actualized by Peter Janetta, placing a Teflon sponge between the vascular loop and the nerve root to provide relief. At 20 years, 63% of patients who undergo an MVD still have relief, and this is the best treatment we have for patients with a neurovascular conflict. If they do not have a conflict and or if MVD is unsuccessful, there are other neuroablative procedures that can be offered, but they're less efficacious, like glycerol rhizotomy, balloon compression, and gamma knife radiosurgery. Unfortunately, this disease has a terrible moniker, the suicide disease. There's a significant loss of quality of life in these patients. They avoid eating, socializing, and they often lose employment. So this is a very significant disease for those affected. One target for chronic neuropathic pain is the central lateral nucleus of the thalamus, particularly the posterior aspect of the nucleus. It was previously considered the medial thalamus. It is a node in a loop called the thalamocortical dysrhythmia that is thought to underlie the chronicity of this syndrome. It transfers nociceptive information from spinal thalamic tracts to the secondary somatosensory cortex and eventually the insula, anterior cingulate cortex, and prefrontal cortex, which is thought to underlie the motivational and affective components of pain. Jean Monod is really a leader in this field and an inspiration to us. He's described his case series of performing central lateral thalamotomy using stereotactic radiofrequency ablation, where he targets the CL nucleus 2 millimeters posterior to the posterior commissure and 6 millimeters lateral to the thalamoventricular border. He treated patients both with bilateral and unilateral CLT, and on his follow-up he found that 53% experienced greater than 50% relief on the visual analog pain scale. He found better outcomes in intermittent pain in patients with peripheral etiologies. We ourselves just finished our clinical trial using bilateral focus ultrasound central lateral thalamotomy for chronic refractory neuropathic pain. We were looking for patients with neuropathic pain that was refractory to medication and to surgical interventions that could undergo this procedure. So far, 10 patients have completed the trial, 9 were successfully ablated, and 8 were bilateral. So we have 17 CLP nuclei successfully ablated. There have been no serious events. There's been a noted decrease in medication use among patients. And in terms of our pain outcomes, which we used dynamic scales that really probed the quality of life aspect of this disease, On our brief pain inventory, we found a 46.3% decrease. On our pain disability index, we found a 39.3% decrease. And on our numeric rating scale, we found a 42.8% decrease. We found that episodic pain with an allodynic component responded best to this intervention. Our intent is to enroll 10 patients to perform bilateral focus ultrasound central lateral thalamotomy. John Manat's group showed that thalamocortical dysrhythmia evidence exists on both sides of the brain, regardless of the side of pathology. So we, again, wanted to treat patients bilaterally. This is a single-arm, non-randomized, unblinded study. We wanted to evaluate the safety and feasibility of this intervention in the treatment of refractory trigeminal neuralgia. And then we wanted to evaluate the efficacy using pain scales, including the Brief Pain Inventory Facial, the Barrow Neurological Institute Pain Intensity Scale, and the patient's global impression of change. We wanted to include patients with chronic severe treatment refractory trigeminal neuralgia. We wanted to include patients between the ages of 21 and 75 that have had trigeminal neuralgia for more than 6 months and failed medical management, 2 medications, and also failed surgical management or were ineligible for surgical management. They had to be capable and tolerant of focused ultrasound treatment and essentially did not have any other CNS disease or prior deep brain stimulation. So far, we have treated 5 patients, 2 females and 3 males between the ages of 36 and 67. They've had trigeminal neuralgia between 3 and 21 years. And as you can see, several underwent microvascular decompression. Patient 5 was ineligible for that, so they underwent gamma knife radiosurgery. They were on many medications, and they were on several medications right up to pre-op. We've treated all of these patients with bilateral focused ultrasound thalamotomy of the CLP, and the average sonication time was 128 minutes, so just above 2 hours. At 6 months follow-up, there have been no serious adverse events for any of these patients. 4 patients had headache or pin site related tenderness from the stereotactic frame we use. All of those are resolved. 1 patient had nausea and anxiety, which was resolved as well. In terms of the brief pain inventory facial scale, at baseline the average was 101, and at 6 months the average score was 32.8, representing a 67.5% decrease on average, which was significant on an independent samples t-test. And you can see the progression of the pain scores over 6 months. The BNI pain intensity scale was also used. At baseline, the mean was 4.4, and at 6 months, the mean was 2.6, representing a 40.9% decrease, which was again significant. With the patient's global impression of change, the average was 1, no change at baseline, and at 6 months was 5.4 on average. And again, this was a significant increase. This is an example of bilateral central-lateral thalamotomy 1 day after the surgery. You can see there's edema around the lesions. We also supplemented our targeting with F-gator MRI, which would delineate the medial dorsal nucleus and medial pulvinar nuclei, between which the central-lateral nucleus sits. 1 patient stopped their oxcarbazepine, 1 patient stopped their baclofen as well. We conclude that bilateral focused ultrasound central lateral thalamotomy for refractory trigeminal neuralgia is feasible and generally safe. This is building on our prior neuropathic pain trial. For patients with refractory trigeminal neuralgia, this intervention is associated with improvement on validated quality of life directed pain scales. Of course, a future study with a control arm is needed. This intervention may result in a reduction in pain medication use. These are my references. I want to thank Dr. Gandhi. He has been an incredible mentor without whom I wouldn't have my involvement in focused ultrasound like I do today. An exceptional human being, physician, and mentor. I also want to thank Dr. Eisenberg as well. and the Focus Ultrasound Foundation, and of course the entire University of Maryland Focus Ultrasound team.